Dear colleagues, good afternoon. Now I'm opening the session. The topic of the session, endometriosis and reproductive surgery in the 21st century. So I think that this session will be most attractive session and most adrenaline session. And we have three speakers, three very well-known speakers, and we are going to discuss surgical approach in DA and tubal surgery and also fertility outcomes. So now I would like to invite the first speaker, Professor Arnaud Wattiez. All you know him very well. He's the very excellent surgeon, excellent laparoscopic surgeon, and now, if it's ready, we can start.
It's not bad. Thank you. Thank you, Fatih, for the introduction. Thank you for the organizing committee to invite me, and especially thank you to Mustafa for the, now we can say, long friendship and a lot of nice work to be done together, and I hope a lot of future work to be together. And so the topic of my talk is surgical approach in young patients affected by DIE. And so the problem we have nowadays is it doesn't come out in the epidemiology so far, but when you deal with endo, you get the impression that you have more and more severe cases in younger patients. Years ago, 15 years ago, mainly we were around patients around 30s, and nowadays we deal more with patients around 20. And so the problem when you have a young patient is not the surgery itself, because you will see that once you decide to do surgery, you do what you have to do, but the problem is to decide if you have to operate or not. And if you decide to operate, is when to operate, and probably how to operate. And the main question is how to preserve fertility, because those patients are not reputed to be infertile, because most of the time we don't even know if they are fertile or not, because they never tried to get pregnant, but they would like to get pregnant in the future. And so the issue is this, how to preserve their fertility. And I am a surgeon, and I look at my job, with humility, and I know that we do a good job for those patients for pain, and unfortunately we leave behind us a lot of side or collateral trauma or defect. And so if you look this picture, for example, this is a picture we get a unilateral cystectomy for endometrioma. And when you see the picture, you see the right ovary, which is normal, and the left ovary, which is dramatically reduced. And so I do not say that it's always the case, but this is an issue that should be discussed. If you look on this small video, you see that this is not an adhesion which is due to endometriosis. This is an adhesion which is due to surgery. So we leave behind a lot of adhesions, and those adhesions are not very well for fertility. Now you have also risk on that patient, risk to not operate or to not operate well. And so this patient has been operated, and you see that not only she has adhesion, but she has remaining disease. And so if you decide to operate, it's better to operate and to be probably more radical and to excise all the disease. Now, we have a clear risk to not operate. And this is a patient that I operated 2 days ago, 24 years old, and you look what you think to be where I am. What you think to be an hydrosalpinx is in fact the right ureter. And if you look this one, this is the left ureter. So this patient already lost the left kidney, 24 years old, and is losing the right one. And so the surgery should have been done long time ago and has not been done. This patient has never been operated before. And so when you look the dissection and you look about how the ureter on both sides were totally invaded by the disease, this should have been done before. And so we have to decide. We have young patients with severe cases, when to operate, when to not operate. And probably, I mean, that some words will be given on the progressivity of the disease. And even if we not all agree if that disease is progressive or not, at least we agree that it starts by nothing to go to some point. And so this is a benign disease, and we have to consider it. So when people say we should do an oncological approach, I think this is totally wrong. That affects younger and younger patients. And in my center now, we deal with a lot of very, very young patients. And again, we have to preserve the fertility. And so one word about preserving fertility. There are a lot of solutions, I think, and some could be during surgery. We can do partial surgery. Let's say if you have a patient with, let's say this patient with the ureter, you can treat the ureter and leave the rest behind. We have no idea because we have no data. I think we can better do an economical surgery, and this is what I'm going to develop after. We can do all these, what you know better in this Congress, all the things around the oversight pickup, preservation, frozen ovary. And also now, you have new things that probably in the field of IVF will probably change the way we do surgery, is the in vitro maturation of primordial follicles. And so sometime we as surgeons, we face a condition, for example, mainly for the left annexa, where we know that the annexa is really in bad shape and condemned, and as the patients are young, we still want to keep at least the ovary. And so it could be that we have now to remove the ovary, to give the ovary to some lab that they will get out all the follicle, will mature them and frozen them. And so this could lead us to do more annexectomy in the future that we were doing in that time. So this is, let's say, a permanent equilibrium, balance, and so very challenging disease, so that leads with very challenging surgery. And the question is why we have to discuss this, because as this is not a cancer, we do not have to make an optimal cytoreduction. So I mean that in cancer, and mainly in advanced cancer or ovarian cancer, we know that if you do surgery, you have to be optimal. So I mean that you have to make a cytoreduction to 0. And 0 is 0. If you have 1 centimeter cube left, the survival prognosis change. It's not the case in endometriosis. This is a benign disease, and we can accept to leave some disease behind. And this is a question we should address, and mainly when we talk about young patients. So now, if you look, and why we do surgery on those patients is because of the dramatic impact on the quality of life. And those patients, I do not say that we should jump on all young patients and to do the surgery. I just say that most of the time, the primary line therapy is to give a pill, to give some hormonal treatment, but most of those patients, escape to the treatment and still live with pain, and this pain, just lead to absenteeism, to social destruction, familial destruction, divorce, and everything. And so, I mean, in addition of that, surgery is efficient. We have very good results in terms of pain. And if we have time, I will go to show you some results. If not, I will leave it with you. But if you look at the literature, we are very efficient in dyspareunia. We are very efficient in dyschezia. We are a little bit less efficient in dysmenorrhea because probably the adenomyotic factor, but we are very efficient. So surgery is an option, and this option is probably for young patients not the first-line therapy, but it's still an option. But then when you go there, and most of the time this is the let's say, the perversion of the story, if we go to do surgery in very young patients, is because we are facing a severe situation. And severe situations affect many organs, most of the time. And so those patients do not have only endometrioma. So endometrioma is an issue, but it's not very complex to solve. So now the patient you have seen the picture before is an issue to solve, is a challenging surgery, difficult, and expose the patient and the surgeon to high risk of complication. So if you go there, you have to know how to deal with ovary, with vagina, with uterosacral location, ureter vessel, bowel, and nerves. Now, nerve is a discussion I will try to give some words by the end of my talk, but nerves now is a real issue that we have to discuss. So surgery with this is challenging because associated with a high risk of post-op complication. And post-op complications are a problem, but mainly we know how to deal with it. So I mean, we know how to deal with hematoma, we know how to deal with fistula, leakage, whatever. We know how to do that, and when you are trained in this kind of surgery, you know that we follow this patient very carefully, and if we have any doubt, we very rapidly go back for a second look, laparoscopy, to check everything. And if we have leakage, we can do a diverting stoma. We have no problem to fix it, and the patient are informed before. So this is the issue. The issue is not there. So the issue for the young patient is what happens in the long term. So in the long term, we see now more and more bladder, bowel, and sexual dysfunction appearing from the surgery. And as we see also de novo adhesion that impair the fertility. And so we are more, we surgeons, preoccupied by those conditions than by the post-op consideration. And this is normal that we have those complications, because we know since long, and this is a study from Chaperon, which dates from long already, that showed that more you go to radicality, more you increase complication, more you have numerous organs involved, more you have complication, and more you touch the bowel, more you have complication. And so when you look this patient, they have many organs involved, most of the time the bowel, and we try to be radical. So we have an addition of risk factor for complication, and so that's why we have complication, and we should know that. And so always the story on this is to balance between radicality and function. And we have to be radical towards the disease, and we know that, we have evidence. But as well, we should be conservative towards the function, and especially on young patients, they should leave the hospital or the clinic. They should leave with all function working properly. And this is a challenge. And so we have to not undertreat, but we are certainly not to overtreat. And this is where the surgeon is important, and the surgeon should make an arbitrage at all time. And again, we know that excision is better than coagulation, but we also know that sometimes we can leave some disease behind. What is best? To leave some disease behind and get some residual pain that could be treated by medication, or to lose the control of the bladder. And so amazingly, the answer is not so clear. And I have a recent example, a patient, we have a full atonic bladder 15 years after surgery for endometriosis, and I ask her the question, I say, look, what would you prefer? To get the control of your bladder now and to get some pain left, or are you okay like this? And she told me, without any hesitation, I prefer the way I am. And so you know that sometimes we think, we as doctors, that we have the answer, but not always. So excision, whatever is the best approach, and we have evidence that it gives the best cure rate and you avoid the recurrences. And so if you look excision versus coagulation in the literature, and mainly we know that since very long for peritoneal implants, we know that you resect them, you have much more efficient, and specifically in terms of fertility, and we know that in 97 with the Marcus story, that has been also confirmed by the other story after. So we know that for implants on the peritoneum, better to remove them. And this is what we do. And this is not associated with a lot of risk. When it comes to the bladder, for example, It comes to the bladder that we know that partial cystectomy are much better than coagulation. Why? Because coagulation has been tried, mainly by urologists, and it leads to incomplete treatment, so the recurrence rate is almost 100%, and we have also late complication with a missed hole in the bladder after coagulation. And so the complete excision of the disease is associated with the total resolution of the symptom, and if you do partial cystectomy, it's almost 100% of good results. But you have a risk. This is the small bladder syndrome. So again, if you have the nodule very low, close to the trigone or inside the trigone, you can create post-op small bladder and you can create post-operatively unstable bladder. So what is your choice? Could we do a partial cystectomy? So we have no data, but probably we have to be economical. If you look the ovary, I think the ovary is the main issue and the main discussion nowadays, and specifically in the middle of the IVF people. And so IVF people say, now we can deal with small endometrioma, we can still stimulate patients, we have a good rate of stimulation, we can also pick up, and sometimes at the same time we can also puncture the cyst. And so I mean, but nevertheless, we know that still excision is better than coagulation or drainage, because if you do a drainage, you have a higher recurrence rate that leads most of the time to repeated surgery that impair the ovarian function. So we know that cystectomy in the opposite has much less recurrence, good cure rate, but unfortunately we impair the ovarian reserve. And whoever the surgeon, even the best of the world, we have evidence now that you reduce the ovarian reserve. On young patients that desire to get pregnant immediately after surgery, there is no impact on the fertility, but it could be that if you do this, I remind you this picture, at the age of 22, and then the patient wants to conceive at 32, I mean, that could lead to a problem. And so I think we have to be very cautious and pay attention to this. Rectovaginal location, which is the main location of endo. What means rectovaginal? I don't know really what it means, because anatomically it is not supported by any anatomic localization. But nevertheless, this nodule in the middle of the Douglas pouch, we know that if you remove them, you have much less recurrence. But if you remove them all, you have a high risk of nerve injury. And so you know that the classical rendezvous between the parasympathetic and sympathetic fiber are lateral to the rectum, a little bit lower than the Douglas pouch. And so if you go there, you have a high risk to impair the bladder sensibility, bladder function, and rectal function. And so, but we have also evidence that, for example, that if we have this rectovaginal nodule, if they are more than 2 centimeters, if you want to reduce dramatically the recurrence rate, you have to excise the vagina. Excising the vagina is not a big issue, except that when you open the vagina and if you have other organs affected, you increase the rate of complication, as well as you can develop a new kind of dyspareunia post-op, not due to the nodule, but due to the scar. And so also we have to do it carefully, and techniques there is very important. Uterosacral ligament, this is the main location of the endometriosis. I don't know if you are very aware, but the anatomy of the uterosacral ligament has been discussed extensively the last 5 years, at the point that people think that it doesn't exist anymore, but nevertheless, let's keep it the way it is. So this is the location of, the main location of deep endo. And so, I mean that if you excise and do a complete removal, again, the recurrence rates drop significantly, by more than 3 times. But as we know now the anatomy, so the uterosacral ligament has the medial part, which is ligamentous, but the lateral part, which is neural, and this is mainly the superior hypogastric plexus in his reception of the inferior hypogastric nerve that is touched there, and we have mainly sensibility of the posterior aspect of the vagina, in addition of the motricity and sensibility of the bladder. And so I mean that, again, we have to be exhaustive, and when you think on young patient, we can be exhaustive, but again, pay attention to the nerve, as the risk of nerve injury is high. And if you see in this series from Volpi, that is quite short, but they could identify in 90% the inferior hypogastric nerve, and in 1/3 of this group, they have to resect it. And so, again, this is to start to say that nowadays you have in many congresses a lot of people that talk about nerve-sparing surgery for endometriosis, but this nerve-sparing concept is an oncological concept and fit with oncology, but do not fit at all with endometriosis. And so if you have deep endo within the nerve, is really within the nerve. So if you make an histological cut of the nerve, you will see glands inside the nerve. So the nerve is invaded, and there is no way that you can dissect it. And so you have two choices. Either you leave the nerve with some disease, or you cut the nerve. There is no place for nerve sparing where you say you dissect the nerve, you take it out of the tissue, you remove the tissue, and the nerve stays, which is oncological. And so I mean that we have to pay attention. Now, more interesting is bowel. And bowel is very interesting for young patients because, you know, in almost 100% of the case, when the bowel is involved until the submucosa. So I mean that the muscularis of the bowel is quasi all the time, but something like 90% of the case involved. What should we do? Should we do bowel resection on these young patients? Should we do discoid resection? Should we just do a shaving? That's the question. And so the discussion is still on. And why are we discussing this? Because we do not discuss for the peritoneum, we do not discuss for the ovary, we don't discuss for the bladder, but we discuss for the bowel. And why we discuss for the bowel? Because we are gynecologists. And so we as gynecologists, we are less experienced in bowel surgery. And so we have to call or work with colorectal surgeons, so it means that we should have planned the resection eventually, which is impossible. And so we always have the problem, and in addition, the colorectal do not know nothing about the disease, and will be able to remove the piece of the bowel, but they are able to leave all the disease behind except on the bowel, which is not also the proper treatment. And so we should determine the limits of the technique for removing this disease, and it means that if you, as gynecologists, you don't know how to do a bowel resection, even if you don't do it, but if you don't know how to do it, you will be not able to indicate it. And so this is the limit. So in the past, all those patients were treated by, and mainly the young patients, were treated by colorectal surgeon, and colorectal surgeon has been taught to do segmental resection, sigmoid and rectum for cancer, because most of the time they do that for cancer. And so they do a transmesenteric excision, and this transmesenteric excision has two problems. One is you remove a 25 centimeter long sigmoid and rectum for a 3 centimeter nodule, which is benign. And two, as you are transmesenteric, you hit the nerve, and so you leave behind a bowel dysfunction. And as in addition, they remove 25 centimeters, they have always to dissect the left angle, and always they had a stoma, protective stoma by culture. All those patients has a huge bowel dysfunction. That's why we should not do that. And so it means that all this leads to organ dysfunction. And so we know that this is crucial to save the nerve, as we know that this is crucial to be economical. And we have a lot of techniques. And so we can do shavings, we can do discoid, we can do just simple adhesiolysis, or we can do up to segmental resection. And I think that we have pros and cons. So for example, the shaving, we have evidence now, and I think the best series, the one from Donez, and when you look the complication rate, so I don't know if we speak about the same, that is probably the bias, but let's say that in Donez series, as well as in the Cerrahi one, we have an objective assessment of neurological intestinal alteration after rectal shaving for nodules suggests that laparoscopic shaving techniques preserves intestinal neurologic activity. And so, I mean, the shaving at least has this capacity of, respecting the bowel function. Unfortunately, we know, and after the Remorgida study, that if you do a shaving, you leave in 40% of the patients some disease behind. And so the future of those patients is totally unknown. We do not know what those young patients are going to be. So does this left disease in the bowel, evolve towards a stenosis? Yes, no, we have no evidence, and I think that probably Philippe will give a word on this. So we have done a lot of improvement for bowel surgery, and we have done that because it has been done by gynecologists. And so we gynecologists, we know the disease, and also we know our patient, and also we have a much better cosmetic approach, not only for cosmetic, but also for tissue, compared to the colorectal surgeon. So we place trocar in good zone, we make small incision, we dissect the tissue with more touch, we try to be economical, and so we have developed this economical way of doing segmental resection. And you know that nowadays, when you have a nodule of 3 centimeters, we do a resection of 5 centimeters, and I promise you that the post-op course and the long-term follow-up differs a lot. And so I think the future challenge we have for young patients is really to decide when we are going to operate, and this is addressed probably by failure of medical therapy, evidence of organs compromission like ureter or bowel, and so or very high pain. And when we go there, we have to replace the concept of radical surgery by the concept of economical surgery, which is not antagonist. You can be, and the best proof is the proof of the bowel. We are as radical as they were, but we are much more economical. And when you look the result on the patient, we have the same excellent result in the treatment of the disease with much less risk of post-op, long-term post-op dysfunction. So we have to develop this economical radicalism that start by the peritoneum, the bladder, the vagina, and the ovary, and finish to the bowel. And so we have to do that by a much better knowledge of anatomy of disease and on laparoscopic technique. And nowadays, so we will not get the time to go towards results, but you will see, and we have evidence, for example, for fertility, that the fertility after radical treatment for deep endo by laparoscopy gives twice the better result in fertility compared to laparotomy. And so this has been published, and if you are interested, look on the Cerrahi publication a few years ago. We have to revisit the concept of nerve sparing. So nerve is very challenging, very efficient. People like it. You like to dissect normal nerves, but unfortunately, in that case, they are unnormal. You have to know the disease, and you have to know all the work that has been done and published showing that the nerves are invaded. A nerve is a living organ with a vascularization. We have study on pressure on nerves. If you apply a pressure on 74 grams on the nerve, you cut 25% of the vascularization. So imagine how much force you imply on the nerve when you make a dissection. We know that if you alter the myelin, so the epinechrine sheath, that you trouble the conduction of the nerve, and it takes time to recover. And we know also that if you impair the nerve, it can be repaired, but it is repaired by 1 millimeter per day. So it means that if you touch the pelvis, it can go up to 18 months to recover a full function. And so you have to talk to a patient, and you have to know the techniques to preserve it. And so we have also to work for better management of the disease according to the patient objectives. And so one of the main objectives of the young patient is to get rid of pain and to keep their ability to get pregnant in the future when they want it. And so fertility preservation is probably the key word of this surgery, and we have to work on that. And we have probably to develop a new subspecialty that is very difficult to set up, and we try since years, what I call the pelvic surgeon. And the pelvic surgeon will be the only guy that knows to address the problem of the patient with endometriosis, because he will not only know the techniques to treat the patient, but also he will know everything on the technique. So I will stop my talk here because of the time. So I think the challenge for young patients is really the most actual patient for deep endo, and I thank you for your attention.
Thank you very much, Arnaud, for this excellent lecture. Is there any question from the audience? Yes.
Dr. Wattiez, I have 3 questions for you. The first one, before the bowel surgery, do you prepare the bowel 2 days ago or 1 night ago, or just do it routinely?
Bowel prep?
Bowel prep, yes.
Alors, the bowel prep, alors, we prepare the bowel, but you have bowel prep and bowel prep. So we prepare the bowel in a way we give a low residual regimen for patient for 5 days or a week before surgery, and then we make a low enema the day before until the liquid comes back very clear. So this is what we call bowel prep, which is not the bowel prep from the colorectal surgeon, because yes, the bowel prep from the colorectal is much more extensive and with antibiotic, with everything. So we don't do that. What is interesting is that during the last period, 10, 15 years, the colorectal surgeons were going down with their need of bowel prep. And the main reason was that when you prepare the bowel with those liquids, you have a lot of liquid inside the bowel. And so if you cut a piece of bowel, you have a more risk of dissemination due to this liquid than if you have solid stools. And so they came to the point that they prefer to have solid stool than liquid. But recently, 6 months ago, there are 2 papers that have been published for the American College of Surgeons that shows the result of bowel prep colorectal way, showing that if you prepare your bowel correctly, but again, this is for cancer or sigmoiditis, that you get 50% less leakage. So we are dealing with young patients. We are dealing with a benign disease. And so I think the situation is a bit different. Most of the time, colorectal deal with problem of nutrition, etc. So we don't have this.
Another question regarding bowel surgery. As you stated your slide, they don't prefer discoid or shaving. They prefer bowel resection, in our country at least, and the most of the world. And they don't like it, the shaving, and they don't like the discoid resection.
The colorectal?
Yes, they
because they don't like it because it doesn't exist in their culture. You don't like what you don't know. And so I mean that shaving has been invented by gynecologists, as well as discoid resection. You know, the guy who presented the discoid resection in the world was Harry Rich in '92. And I remember the reaction of the colorectal that said, "You are totally crazy." So now we have studied after discoid resection with very good results. But I mean that still, discoid resection is reserved for very, very small lesions. You can, more than 1.5 centimeter is very difficult to remove all. So I think that, my opinion, shaving, we know that you leave about half of the patient, you leave disease. Fine. Then you have discoid, small lesion. I think that for real lesion, 3-4 centimeter, small bowel resection is very efficient. And we have learned to do it very nicely. So I mean that we don't do anymore a pubic incision. So we have learned to do it, most of the time we have learned to do it nicely. So I think, and the post-op of those patients is very good. So I think, being more sure that you remove all the disease without paying very high price, I think we replace a little bit the economical resection within the spectrum. But it can be discussed.
And the last question regarding ovarian reserve. As you know, the ovarian reserve is very important for us. For the control of hemorrhage, do we have to use coagulation or do we have to use the suture techniques instead of coagulation?
Alors, we never use suture technique for hemostasis. We never use. But some people have done study, and you have a paper who randomly look for suturing versus versus coagulation and say suturing is better, but I
Yes.
cannot understand how you can suture all the small bleeders. So what we do is we use suture for reshaping the ovary if it needs to be done, and to try to preserve some risk of adhesion. And when we have to do an hemostasis, we are very, very precise. And first of all, we tend to wait. And most of the time, 50 or 60 or 70% of the small bleeder stops alone. And then if we have remaining bleeder, we come with the point of the bipolar and just coagulate precisely.
Thank you.
Any question? Arnaud, I have a question for you. We know surgery is effective, efficient for DA, deep endometriosis, but also we have some major complications. So if you have a young patient, a young lady with deep endometriosis, so what's your first choice for this lady? Medical treatment?
If I have a patient with deep endo, it depends on, you have deep endo. I have some patients with deep endo who have no symptoms. So this one I don't even touch. But I mean that if the question is the patient, if you have a patient with deep endo with a lot of pain, most of the time she comes to me and she already got all treatment possible, all surgery. So most of the time there is no issue that you have to reoperate her. I do not say, and I know that Philippe will jump, but I do not say that surgery is the first line therapy and specifically for the young patient. So if you can treat the problem with medication, give to the patient a good quality of life and not too many side effects of the medication. So it means that first of all, the patient should not need to get pregnant because all the medication are contraceptive. And so I mean that this patient, you can keep her under medication and follow her, providing that the ureters are not involved, providing that she has no stenosis on the bowel, and providing that probably if she has an endometrioma, is not too big, okay? So I will not jump on her. So I try for young patients, we have to be a little bit more prudent, but unfortunately, most of the patients we see are coming after the failure of all those things. So we do a lot of surgery, unfortunately. Or fortunately, I don't know.
Okay. Thank you very much. You have a question? Okay. Short question, please.
Okay. If you prefer, if you need to have a return cystostomy, do you prefer to create a Boari flap or what's your technique?
I think you should never, ever, never, never, never do a Boari flat for benign disease. Because Boari flat will lead to small bladder syndrome. And you cannot expose a patient for small bowel syndrome for endo. You can do a direct repair, but if you do mainly the Boari flap is done to reanastomose the ureter. Mm-hmm. Then when the ureter is too short to reach the bladder, even if you do a psoasitch. I think that Boari flap is acceptable for oncology to avoid an anterior resection, but you cannot do it for. You should not do it for small bowel. But honestly speaking, we do 90% of reanastomosis for the ureter, so we can do a direct reanastomosis most of the time, and we do 10% of direct bladder reimplantation. And in this direct bladder implantation, in half of the case, we need to do a psoasitch. But you never need to do a Boari flap for that.
Thank you.
Thank you very much, Professor Wattiez. And next speaker is Professor Wattiez from France. He's going to speak about, is there still place for tubal surgery in the era of ART?
Thank you, Mr. Chairman. Thank you for the invitation. And I changed a little bit the subject, but I stay in the reproductive surgery. First of all, to say that I have no conflict of interest in this presentation. And then, as you probably have seen, this editorial in Fertile Sterile by Derin, he says in 2008, tubal surgery is dead, only the obituary remains. And I will try in this 50 minutes or so to demonstrate that it is not really true. First of all, concerning hydrosalpinx and IVF, as you know, since now a long time, the deleterious effect of the hydrosalpinx, it means that you will double your pregnancy rate in IVF if we remove the hydrosalpinx. And that has been confirmed at a lot of works, first by Deschaux and then by a lot of works, demonstrating that really we do not have to keep the hydrosalpinx. But what we have to do first is to define the lesion, because people in the paper speak about hydrosalpinx, phimosis, and it is really not the same. In case of phimosis, we have still some opening of the tube. Sometimes you may have a big dilatation of the tube, but you have still some passage. And that is not an hydrosalpinx. That has to be treated by fibroioplasty, and the prognosis is totally different. And if we have a total complete obstruction of the tube, then it is an hydrosalpinx, and then we have really to deal with that in another way. We have to do a neosalpingostomy. We will see that in a moment. So we consider today that conservative treatment may give result as good as IVF, depending on three factors: the tubal criteria, the technical skills, and the human criteria. First of all, the tubal criteria, and you see sometimes evident. When you have this kind of X-ray, obviously you know that the only option is to do a bilateral salpingectomy, because we have absolutely no chance to recover the tubes after tubal surgery. But you have to keep in mind that if you just rely on hysterosalpingogram, you may have a lot of mistakes, because in the meta-analysis of Swartz some years ago, it was demonstrated that we have between 20 to 40% of false negative. It means apparently tubes are normal, in fact they are not. It's why we have to rely on something more precise, which is laparoscopy, or sometimes, if you prefer, fertiloscopy. To show you some film. Sorry. Okay. Yes, so fertiloscopy is, you know, a transvaginal laparoscopy, which is probably a good alternative for laparoscopy if you think that the pathology is not that big, because it is by a vaginal way. It is more or less like oocyte collections. So you are creating a space with a saline solution in the pouch of Douglas. Then you insert a special trocar in this pouch of Douglas with a balloon at the extremity. So when you are in, you have no risk to be pulled out. And then you are going to insert a laparoscope, which is in fact hysteroscope, in the central channel. And then you are able to be very close, as you may see, to the genitalia. And so you may have a very precise inspection of the tubes in a very, very mini-invasive way. And that it is probably something which is important to do, but obviously laparoscopy will do the same. And if you do that, we have to see precisely the tubal mucosa, because that it is something which is very important. You can see the tubal score of Brosens. It describes 5 steps, from normal to abnormals, and there is really a big difference between normal tubal mucosa and abnormal, because if you have hydrosalpinx, and if you treat patients with level 1 or 2, you see that the pregnancy rate is roughly 65–70%. If you have a bad score of tubal mucosa, you will have only 20% of pregnancy rate. So definitely, if you have this kind of patients, we have to go directly to IVF. You cannot treat this patient. We may, on the contrary, discuss when we have a good tubal mucosa to treat this patient. Then to show you how it is when you have this kind of Okay, just to show you this small video to show during a fertiloscopy how you can see the mucosa. You can go inside the tube and you see this tubal mucosa with the dye coming through. When you have this kind of tubal mucosa with very good folds like that, parallel, then you may see that this tube is normal, the mucosa is normal, and if you have this kind of tubal pathology, then it is worth the case to operate this patient because you know that the result will be very good. Then the second factor is the technical skill. You have to have some experience if you want to deal with that. And you may see this paper published in 1990 in UK that evaluate the pregnancy rate after salpingoneostomy in 2 general hospitals with only 5% of pregnancy rate, which was very, very low. And when you see that, you may say, okay, we have to stop to do tubal surgery. In fact, if you have specialized centers, you see that we may have a pregnancy rate which is around 40%, which means that at that time we are becoming competitive with IVF. Then there is the technical skill. We have to know that the salpingoneostomy in racket form is better than a cuff salpingostomy, is less good than a cuff salpingostomy. It means that according to your technique, you know that some are better than the other one. And if you can do a cuff salpingostomy, I will show you that in a moment, it is much better. How to do it? We have to apply the macrosurgical principles. They are not new because it was described by Winston in 1977. What they are, it is the no-touch technique, the magnification, the irrigation, acute but economic hemostasis, and microsutures are much better than the floral effect when you do eversions, and that is very well achieved by laparoscopy. So today, what we've done in the past with laparotomy and microsurgery, we can do perfectly well with laparoscopy. So some example, to deal with hydrosalpinx, first we have to try to find the old osteum. I go quickly because I have a small video to show you. And then you have to open the tube and to fix the eversion. I will show you that on a small video. Okay, go a little further. Okay, so usually we have to start the operation by adhesiolysis. We can do that, in this case, we do that with a plasma jet, but it is, more or less, I will say, a gadget. We can perfectly do that with scissors and bipolar cautery. What it is important is to try to avoid to do what I done at the beginning, which is to create, some injury on the peritoneum, because you know that if you create this kind of injury, you immediately have some recurrence. So it is important to try to avoid that. When you have extensive adhesion, like in this case, it is probably better to cut it and also to remove it, because if you just cut it, you may have, once again, a risk of recurrence, so you have to be quite precise when you do that. And it is very important to remove your adhesions close to the tube. Then when you are dealing with hydrosalpinx, we have to try to find the old osteum. It is where we have to open the tube. We have put some dyes inside to show the patency. And so you have to just make a small hole, and then you have to try to make a gentle dissection to see if you are able to open the tube. And what it is important at this stage, it is the tubal wall. Another examples, usually if you are doing that at the good portion of the tube, we should not have more or less any bleeding, because you are cutting your tube on the fibrotic tissue, like in this case. And you see this hydrosalpinx looks at the beginning very bad, but you see the mucosal go very well after that. And then we have to make the eversion, and to do the eversion, it is important to do some stitches, that it is a cuff salpingostomy. So when you can do this kind of, cuff salpingoneostomy, it is the best situation. And then we have to use, like in this case, it is a 6-0 suture, which is more or less the same that we did in the past during microsurgery. And you have to fix your eversion with usually 3 or 4 stitches. We are using here a 5mm instrumentation. There is sometimes we can use a 3mm instrumentation, which are smaller, but in fact it is perfectly feasible with, I will say, normal instrumentation. What we have to avoid is to make extensive coagulation. You see on my tube there is a white piece that it is not the best. We have to try to cover it. It means probably at that time there was some bleeding and I was obliged to make some coagulation, but it is the thing that we have to avoid the max if you can. And if possible, we have to take a stitches with some color. You know, this one is without color, so it is a little difficult. And then at the end, I think we'll see another stitch. And you see this tube is in a good position because the mucosa is good, the tubal wall is very supple and thin. These are the best criteria to have a good result when you do this kind of surgery. And at the end, we have to wash copiously. And you see that now we have the good patency of the tube. And this patient became pregnant 6 months after that. So if you do that, what kind of result can you expect? You see, in case of neosalpingostomy, we may have 26% on this quite old series. We have our series in Lyon, and you see, if you look to the fimbrioplasty, it means that when you have some patency, we may expect to have 50% of pregnancy rate. When we have hydrosalpinx, you see there is a big difference in our series between microsurgery and laparoscopy. In fact, there is a bias. It means that the first period, we were doing almost no selection. It is why, you know, the results are not that good with almost 20% of pregnancy rate. But if you do a very precise selection, then we may get almost 50% of the pregnancy rate, which means that once again, we think that we are quite competitive with IVF. And lastly, we have human and couple criteria, I will say, because first of all, we have the psychological impact of salpingectomy, especially if it is bilateral to a young patient. She knows if you remove the tube that the only option now is IVF. And so sometimes we have patients, we say, okay, I prefer to start to try to open my tubes. And if we have a failure, then we will consider to remove it. Obviously, when you have malfertility, we have also to consider that because in this case, the only option is IVF, so we will be more keen to remove the tubes. And information and consent are critical. I think that it is something really important to do with your patient is to speak with them and to ask what they, and to show them the alternatives for the treatment. So the conclusion for hydrosalpinx is that the salpingectomy should not be systematic, and conservative treatment is a valid option which should be discussed carefully. Now some word about the proximal surgery, because we have two situations, the tubal recanalization after tubal sterilization and tubocorneal anastomosis. And that was done very well by microsurgery. We can do that by laparoscopy, and we can also do that today. I want to show you this video with the robots. And probably it is one of the best, maybe the only one, validated indication for robots today, because if you want to do the same with laparoscopy, you have to be very, very skillful to have the same precisions. And when you see this kind of operation make with the robots, it's exactly the same as we did in the past with microsurgery. So we see we are cutting the proximal end of the tubes. No coagulation or very, very limited. You see that the blue is coming from the uterus, so we have a good patency. There is small bleeding, so we have to make a very tiny coagulation. You see, very precise, no problem. And then you can make irrigation, some coagulation, and then we are going to to start the anastomosis. First of all, there is the first stitch on the meso to approximate both ends, proximal and distal end. And you see that in this case, a robot is useful because you can do that by laparoscopy once again, but it's more difficult. Now, the problem with the robot is the price, and we cannot recommend to buy robots only to do tubal anastomosis because they are not so frequent. But you may use robots on the platform when it is used for other specialties. Then we start the anastomosis itself. So the first important point is to make the first stitches at 6 o'clock. And you see that the magnification is good, so you can really have a precise work. The same on the distal part, and then we do the approximation. And we do exactly the same as now it is the 12 o'clock stitch. And then we can do a second layer. With a very good and accurate precision. Now we stitch. We have to pay attention with the robot because no return of the heaviness we put. So you have to not to break your stitches, and then we make the second layer. And when we do that, we exactly follow the rule established by Winston or Gommel in the 80s, and we exactly do the same technique. And we have, in fact, the same result, and you see at the end, the patency test is good, and the anastomosis looks very good. So the result of proximal surgery, when you do recanalization, we may expect to have between 70 to 80% of patency, 80% by macrosurgery or by robots, and 70% by laparoscopy, except if you are like very experienced, which means that if you are not a robot and you want to do that, probably it is one of the last indications of microsurgery with a small laparotomy. Of course, I speak about the patency because it depends on the age of the patient, and we have usually patients we have around 40, so you cannot expect to have 90% of patency rate, but at least we have the patency. If you are dealing with a tubocorneal anastomosis, then we have pathological tube because it is PID lesions of salpingic isthmica nodosa. Then obviously, since the tube is pathological, you cannot have the same pregnancy rate, and we may expect around 60% of pregnancy rate. To finish, I will want to say some words about endometriosis, perfectly treated by Arnaud, just about the tube, because as you know, usually the tubes are not affected by endometriosis, which is not true. We have sometimes endometriosis, but usually tubes are quite well respected. And we have to pay special attention to the tube during the operation, because very often it is quite long and difficult operations, and sometimes we see after operations some hydrosalpinx, and even during operations some big edema of the tube. So I think it is something we have to say. If you treat endometriosis deep endo to the patient, we may expect between 50 to 60% of pregnancy rate. And we have not to impair this spontaneous pregnancy rate by damaging the tube. So I think it is something which is very important to really pay attention to the tube. It means that probably there is some paper now demonstrating that the temporary fixation of the ovary on the round ligament is efficient, which puts the tubes out of the pouch of Douglas. It is something probably that we have to do. Also to have probably the use of barrier like hyaluronic acid is probably something which is good to prevent the adhesion formation. So once again, it's some part of tubal surgery which I think is important. And so in conclusion, we say that tubal surgery is not dead. I try to have convinced you, I don't know. It could be a good alternative to IVF, providing that we make a good selections and an accurate and endoscopic microsurgical technique. And thanks to mini-invasive tools, I think we should not go directly to IVF before to have a thorough evaluation of the pelvic tract. It means that just to do tubes are normal, it is unexplained infertility with only hysterosalpingogram or hysterosonography is insufficient, because if you do that, we will lose roughly 30% of the pathology. Thank you very much.
Thank you very much for this nice and excellent lecture. Is there any question from the audience? Or tubal surgery? Yes, please.
Professor Wattiez, thank you very much for the excellent talk. As we know, there's a consensus of occlusion of the tubes if there is hydrosalpinx. Do you think that there is, sufficient data convincing that it's a definite conclusion that it's a must to occlude the tubes before IVF?
Yeah, we have some concern about Eshor system in itself, and also do IVF after Eshor system, because sometimes they see that there are premature membrane rupture. So I think that the best option is to do salpingectomy if possible. Now, if salpingectomy is considered as very dangerous because we have, for instance, a frozen pelvis, then you may consider to make a blockage of the proximal part of the tube. But you may know that sometimes you may have a big increase of the size of hydrosalpinx. So we may use clip, or maybe even Eshor, even if we have some concern. But I think the best option remains salpingectomy.
What about trying the first cycle, by omitting doing the occlusion? Instead of occluding the tube, go directly to IVF.
Instead of what?
Can it be an option to go directly to IVF, in vitro fertilization, to avoid occluding the tube by surgery?
So what option to avoid to occlude the tube? It means to do the IVF with the hydrosalpinx?
Yeah, doing the IVF instead of occluding the tube, depending on the patient profile.
Yes, once again, it is a question, I think, of information, because we know that if you do that, we will have a lot of, we have less pregnancy rate. So we can say the first time we will try to do IVF without occluding the tubes, but we know that we decrease your result.
Okay.
Yes, please.
Thank you for your nice and very informative talk. I was just wondering, you got very nice figures in terms of pregnancy rates. Would you please say something about ectopic rates?
Yes, you're right. It is always a risk. As you know, it is also a risk, even if very limited during IVF. When you do salpingoneostomy, in the literature, the risk of ectopic is between 4 to 7%. So it is not nil, and it is something, you're right, that you have to mention to the patient. But as you know, once again, it is a question of selection. If you only keep the good case, you will reduce the number of ectopic, and in our theory, we have only 2% of ectopic, which is consistent with IVF, because as you know, in IVF, we may have also some ectopic.
Professor Wattiez, is robotic tubal anastomosis cost-effective when you compare to IVF in your country?
Cost-effective, I'm not sure, because we have no data about no, it depends. If you plan to buy a robot for only tubal anastomosis, obviously it is not cost-effective. So I think we may use the robots in a platform, for instance, in the general OR, and then if you use for almost, I will say, limited cost, then it could be cost-effective. If it is only for doing that, the number is very limited, and therefore it is not cost-effective. But now we have all the evidence that tubal anastomosis give better results than IVF, but it is not cost-effective by robots. That's for sure.
Okay. Thank you very much.
Thank you.
Now Now we are going to next speaker. Professor P.Konninckx. All we know him very well. Now he's going to talk about surgical environment to enhance fertility outcomes.
Mr. Chairman, it's always a pleasure being back in Turkey, but for me it's the first time in Cyprus. I was looking at the hashtag IVF and beyond, and what I would like to do with you today is to give a short overview to say that reproductive surgery today is what's beyond IVF. To get a long story short, when we talk about surgery and infertility, we think about two things. That's first adhesions and ovarian damage. And we know that after surgery, 80% of women will have adhesions, that of all those who have infertility, 30% is due to adhesions, and we also know that adhesiolysis is not very effective. And ovarian damage, this is the whole story of oocyte reserve. The second introductory point I would like to say is that should we do a laparoscopy in infertility? It's a long story, exists since always. If the woman has pain and a possibility of endometriosis, I think the answer is clearly yes. If there is a big endometriotic cyst also, if there's an absolute male infertility, probably not. And in between, you have a calculated risk. But just for those who doubt, I always like to show this. I have seen one patient like this in my life, but she was with the two tubes attached to the abdominal wall for a reason I don't know. It's very clear that this takes 3 minutes of surgery to cut the adhesions, and she gets pregnant. There is no test, no way to diagnose this without a laparoscopy. And this is one of the reasons I think in a fertility workup, a laparoscopy has still a place. And if you do a laparoscopy, a diagnostic laparoscopy, probably it's better to do the surgery if you are skilled to do it. And then I'm not going to overview all the indications for surgery. Absolutely, indication can be discussed and so on. The thing I would like to introduce here is the peritoneal cavity. And I start with oxygen. Oxygen is the fuel. We need oxygen to live. We need oxygen to burn, to keep ourselves warm, to have some energy. But if oxygen is not well controlled, we have reactive oxygen species and oxidative stress. And this is very old, known since a long time. This is the study of the oxygen cascade in the body. And we have 20% of a partial pressure of 159 millimeters of mercury in the atmospheric air. And then you see when you go down in the body to the peripheral cell, you have in a peripheral cell 10 to 40 partial pressure of oxygen, which is the same as 2, 3, 4% of oxygen. Come back to this in a second. The second thing is adhesion formation, peritoneal repair. Within minutes, you have this, you make a lesion, within minutes, you have the neutrophils who are there, you have the platelets with that attached to the lesions. Within hours, you have this fibrin mesh. And by the end of day 1, you start epithelial repair. And by day 3, it's completely gone. No adhesions, full repair. And you see, this is because it starts from many islands, and it's also the reason why a big area or a small area has the same time to be recovered. If, however, day 3, you do not have a repair, at that moment the cascade has started and you have already this kind of fibroblast proliferation, and you always will have adhesions. And if by day 5 it's not done, angiogenesis starts and you have adhesions with this kind of vascularization. So if this local lesion, you have something that maintains the inflammation, at that moment you go for adhesions. And what is this? Too much necrotic tissue, too much sutures, hypoxia, oxidative stress, infection, ischemia, reperfusion. To translate this for the surgeon, I would say this is pinpoint hemostasis, not this big hemostasis with a lot of necrosis. Not strong sutures, which always will give hypoxia. You approximating sutures in order to keep the blood flow, and think about the innovative aspect of the circular staple of the bowel, takes this into account. Maybe non-resorbable suture, and don't use sutures which are bigger than necessary. And then you have the whole story of the barrier treatment, where you have 40 to 50% reduction adhesions, but not proven for fertility, for reoperation rate, for pain, and so on. What I would like to tell you today is that in the peritoneal cavity, there are a lot of factors, and this is much more important for adhesion formation than the local lesion. And this is what we published in Fertility last year. You have, this is the local, but much more important is something which is acute inflammation in the whole peritoneal cavity, and this causes pain, adhesions, recovery, CO2 resorption, metastasis, a little bit too long. But the mechanism you have to know is the mesothelial cells. Mesothelia within seconds starts from this kind of contiguous layer, start to retract, and after half an hour you have bulging of cells, and after 2 hours you have this situation. Something which is very well known, and after surgery, but in order to get there, we have to use air to open up the bowel, have CO2 for laparoscopy, we need manipulation and so on. By now we know what are the bad factors and what are the good factors, and hypoxia, hyperoxia, desiccation, temperature, blood and fibrin, saline. I'm going to review this, I hope not too fast. The common factor is acute inflammation, and acute inflammation is this what starts after 10 minutes, which means before you have put all the troch as you start your surgery, the acute inflammation, if not well done, is already on its way. And the first thing that's wrong is saline. We know this since 1971, and we all had forgotten it. That's why microsurgery used Ringer's lactate. And you see that saline is toxic for mesothelial cells. They float off. We know this since long. There's retraction and so on. I'm not going to say what is the ideal culture medium, but the first message today, throw away saline and use at least Ringer's lactate, or better if you can have it. Very well demonstrated at this moment that NaCl, just from the moment it touches, is already toxic, and then the effect is worse and worse over time. Most of these experiments are done in mice because they are cheap and we could do them. One of the first examples, this was Ron Schoenman from Tel Aviv who demonstrated this, is that if you manipulate the bowels, just manipulate in the upper abdomen, you have more adhesions between opposing lesions in the lower abdomen. So there's something which is coming through the peritoneal cavity. It's time dependent, it's motion dependent, all this is done. The second thing, Yirmibirinci is from Turkey, in fact, and he demonstrated, this was one of the first observations in mice, that if you leave the CO2 pneumoperitoneum, you have more and more adhesions, at least up to 100 to 120 millimeters. We never did this. And the reason for this, there are a lot of experiments. We are able to demonstrate that this was because of hypoxia. The superficial layer with the CO2, there's no oxygen in it. And with this you have hypoxia, probably causing ROS, reactive oxygen species, to lowering of the scavengers. And it's exactly the same thing that happens with open surgery. With 20%, there's too much oxygen there. And this can be prevented when you use the right concentration of oxygen is around 4%. The effect is only very, very superficial. This is effect of the mesothelial layer and the few cells underneath. The second thing, what you probably all know, is desiccation. Desiccation is bad, and the more desiccation you have, the more adhesions you're going to have. But you see already that with hypothermia, with decreasing the temperature, you almost have no effect of this desiccation. And this is something what we read, this was the next factor, this is cooling. You all know that the thermoflator has a heating device. This was a historical mistake. It was introduced by Sam at that moment, historical mistake, because the higher the temperature, the more adhesions you're going to have. If you cool, at least cool to 31 degrees, and even, we were able to demonstrate this in women, you can cool to 25 degrees, you're not going to affect the core body temperature, because the abdomen does not belong to the core body. The core body is the heart and the brain. So all this is very clear, but because desiccation causes cooling, that's what we know, 37-degree humidified, and this is cold and dry. What in fact we need is to have cooling with a third means. At least do not heat and use irrigation fluid which at room temperature. I think is the easiest solution today. And then you know, since a long time, they have a lot of discussion about nitrous oxygen. It's less pain, less adhesion. There is a lot of advantage, but there is an explosion risk. And when we did this kind of dose response, we saw that from 5–10% onwards, we already had the same effect as with 100% of N10-O. When we did this in detail, you see that you have a drug-like effect with the half maximum effect around 2.5%, and from 5% onwards, you have a full effect, which is the same 5 or 10 or 100%. This is nitrous oxygen from 5% onwards has a very strong effect. And to demonstrate how strong this effect is, when in mice you add blood in the peritoneal cavity, you have more and more adhesions. And if you add nitrous oxygen, this effect is almost completely gone. It's the single most effective prevention of adhesion formation. It's even more strong in open surgery. And in this experiment, you see the difference. The blue bars and the red bars is the difference between humidified and non-humidified. If you go from here to there, this is the effect of oxygen. It's significant, but it's not so much important. And this is the effect of nitrous oxygen. It means adhesions are almost gone, even more true in open surgery. This is when we knew that, we turned to demonstrate this in the human. And we did a trial on full conditioning. And full conditioning is 10% N2O, cooling, no desiccation. Dexamethasone at the end is coming back also. We demonstrate in this model that if you have given this kind of conditioning, dexamethasone is very effective, and maybe heparin. We did this as a proof of concept with full conditioning, and at the end, the hyaluronic barrier gel. The reason why is because in mice we were able to demonstrate that the adhesion prevention effect of conditioning is 85–90%, and a gel alone has an adhesion prevention of 40–50%. If you put them together, you have no adhesions left at least not an animal's model, and this is the reason why we wanted to demonstrate this in the human. We did a randomized control trial in deep endometriosis surgery, because this is severe surgery for a long time. And to our surprise, when this is used, the full conditioning, any barriers, there are no adhesions left. In one woman, I saw a very small, thin remaining adhesions. In the control group, there is a lot of adhesions, as is expected. And this is comparable to women have less pain, they have much less, it's going from 4 to 1, which means the nurses say those who had conditioning, they wash themselves and the others are still in bed the next morning. Have a much faster recovery. Shoulder pain is gone completely, and by day 1, 9 in 16 were independent. And then what is maybe at first view less important, you do not have CO2 resorption, of much less. We just finished a trial in Whipple surgery, the pancreatectomy by laparoscopy, which is surgery will take 6, 7, 8 hours. There is a big problem when you do it without N2O, without conditioning, of too much CO2 resorption, because you sit here, you see this is only 2 hours in gynecology, but it does not increase the CO2 resorption. Come back to this in a second. Did a series of other trials in order to prove this. So I think we have a conclusion that in the human, everything what we had found as a mechanism in mice seems to confirm retraction of cells, acute inflammation, and then you have deeper penetration of CO2 and pain and adhesion and so on. But I said that what is beyond IVF is reproductive surgery today. We wrote together with Victor Gomel a few articles on this last year in Fertile Sterile in Views and Reviews. And you see, microsurgery, the principles, lessons from the past. I had very long talks with Victor on this, on the phone and together and so on. In fact, everything what I did in microsurgery seems to be proven later. And the proven later, this is what I would say today, is how should we prevent adhesions? On the way of pathophysiology, this is one of the slides in the article. Prevent acute inflammation of the peritoneal cavity, gentle tissue handling, gas with 10% N2O, cooling, no desiccation, Ringer's lactate. Prevent inflammation at the trauma site and in the peritoneal cavity, no blood, no debris, a lot of lavage at the end, and dexamethasone. And keep denudated surfaces separated. And then for those who are interested in fertility, if you have deeper and deeper CO2 resorption, if you do ovarian surgery, what do? You hang a flap of ovary in pure CO2. If you have 2 millimeters penetration on both sides, I'm surprised that I still want oocyte alive. So I think and I hope that in the future we will be able, that this also is going to be important for preserving the oocytes. So if I say IVF and beyond, surgery without adhesions and without ovarian damage requires a skilled reproductive surgeon. Reproductive surgeon, somebody who knows when to do what. And skilled, he needs the skill because a faster surgeon is better for this. Less manipulation is better. You need dissection, and this is the technique of surgery. You need dissection and pinpoint coagulation, not this kind of broad coagulation of everything. And then you use thin approximating tissues. Do not strangulate the tissue, but just approximate it. You have to use the right irrigation liquid, and at this moment, Ringer's lactate is probably the best to start with. You need the right environment with 10% N2O and CO2 in laparoscopy and laparotomy. Both of them are feasible, and maybe oxygen, but it's not clear if this is useful. Cooling with the third means. You have to be very meticulous on prevention of infection, which means each time you open the vagina, like for instance a deep end endometriosis section, give antibiotics. Lavage, don't leave blood, don't leave foreign tissue. Dexamethasone at the end, and then you have an adhesion barriers. And with this, today, I think we can do surgery without adhesions and without ovarian damage. Just think what an impact this is going to have on fertility and IVF. Thank you for your attention.
Much for your nice lecture. Because of time, I can get just one question. Is there any question from the audience? Philip, do you use adhesion barrier routinely in your practice?
Well, at this moment we use everything. And
What kind of barrier?
Well, all barriers probably are the same. I think also if you understand the mechanism, all the barriers are not very well made. It is better to have a barrier which does not stay that long. At this moment they have a retention time of 10 days. I think 5 days would be enough and even less. But maybe why we used hyaluronic barrier gel, this was for practical reasons. Also the ethics committee asked us to use hyaluronic barrier, but I think you can change it any other barrier.
Okay. Thank you. And I'm closing the session. Thank you for your attendance.
On implantation failure, and today we will have 5 distinguished panelists. I would kindly introduce them to the floor, please. Dr. Orvieto, please, Dr. Harper, Dr. Yakın, Dr. Chiang, and Dr. Zeyneloğlu.
Konuşuyor, geliyor mu? Problem değil, olmazsa mikrofona konuşurum, şimdi duyuyorum. Tamam. Bilmem, sahneye çıkacağım.
Actually, çalışmıyor çocuklar. Actually, recurrent implantation failure is a huge topic. I mean, it's very difficult to cover all the aspects of recurrent implantation failure. But I mean, we have only 1.5 hours time, and we will be discussing the several aspects of recurrent implantation failure. I arranged 5 questions, and we have 1 person from the lab side, and also we have 4 clinicians, and we will be discussing all the possible relevant issues for recurrent implantation failure. So the first question is, heart failure, what does it mean? Does RIF exist? Is it a made-up disease? Is it a diagnosis or an experience? Dr. Orvieto, please.
An excellent question, because actually there is no one single definition, I think, for RIF. There are the definition of Margaliot, the definition of Eschre, and many definitions. So first of all, we have to define RIF. So is it after 3 transfers, fresh, frozen? How many embryos are we supposed to transfer? Should they be top quality embryos? So actually, I think that the first thing is, what is the definition? So if they accept the definition of 3 transfer of at least 5 or 6 top quality embryos.
So what I mean in the area of single embryo transfer, the blastocyst transfer, and in the area of so we do not. That's why I put this question. So personally, what is your definition?
So it would be probably after 3 transfer of single embryos, single blastocyst.
So you say
3 blastocysts.
Fresh or frozen, regardless.
Never mind.
Okay.
Same.
What about Dr. Chiang? Unfortunately, we have to share one of the microphones, so yeah.
That's all right. So those of you who were here this morning will see that I listed a whole series of permutations of the definition of recurrent implantation failure that's currently being used by researchers, by clinicians, by you, by me. There's yet to be firm consensus. So I think in practice, of course, we will all have our own definition. One of the most common one will be 3 cycles of failures after a good quality embryo return or transfer. So I think we are yet to understand the pathophysiology around implantation and receptivity fully.
Dr. Chiang, regarding the definition, rather than all the pathophysiological processes. So what is your, personally, what is your personally?
Yeah, so as I said, so my personal definition would be same as actually my speaker next to me, which is 3 cycles with a good quality embryo. That in this context would be a blastocyst.
Okay. What about Dr. Harper?
So I'd like to I'd like to consider 2 things. The first is in natural fertility, we would give someone at least 6 months, a year, to try and achieve a pregnancy before we would say that they should take things further. But in IVF now, we're expecting so much. We're expecting 100% pregnancy rate almost from our patients. So sometimes after 3 failed IVFs, even with good quality embryos, there may not necessarily be something hugely wrong. So I think, is it made up? Is it something that is really there? I think for some people there is a problem, but I think for others it may just be very unlucky. And following into that, the second point is that it obviously depends on the patient's age. So if we're looking at a young patient in her 20s who has 3 failed IVF cycles, I wouldn't treat that the same as if we had a 41-year-old with 3 failed IVF cycles.
Thank you. Dr. Yakın?
Well, we have a long-standing challenge in definition of recurrent implantation failure, I guess, just like we do in many other definitions in this business, like recurrent miscarriages or poor ovarian response. So there exists another confusion in definition. The classical definition is the failure to achieve a pregnancy despite the transfer of good quality embryos, 4, let's say, good quality embryos, in 3 transfers, whether it be fresh transfer or frozen transfer. But in the era of blastocyst stage transfer, now it has changed. We can reconsider recurrent implantation failure if we have to give such a name. We will discuss whether we need to give a name or not. But in the era of blastocyst transfer, failure to achieve pregnancy despite transfer of 2 good quality blastocysts can be considered as an implantation failure. Then the topic would be, do we have to give such a name as recurrent implantation failure? What happens if we give a name? Are we going to do something different for a patient who has 2 failures or 3 failures or 4 failures? But I will wait for that discussion.
What do you see?
Yes, I agree with Dr. Yakın's opinions, and I think after 2 cycles, the couple gets anxious and they are frustrated. In their 3rd attempt, they want to do their best to get the pregnancy. Whatever we define as the numbers of the embryos, let's say 10 as a decade ago, 2 in the recent years, we should respect the patient's expectations. So I think it is 2 blastocyst transfers at the right moment. And I also agree with Dr. Joy's opinion. The age is very important. In the younger patients, we should calm down the couple, but in the older ones, they should speed up.
Okay. I also would like to quote the very recent editorial by Dr. Hans Evers in Human Reproduction is riff-raff. So basically it is, you know, as all the panelists clearly indicated that comparing the natural conception, the monthly fecundity rate, the humerus is very low, the age is an issue, so there is currently lack of consensus on what is the definition of recurrent implantation failure. So the second question is workup needed? If yes, what should it be? And in this context, regarding the female side, regarding the anatomic investigation, should we be screening in a patient with completely normal transvaginal ultrasonography? Should we be doing hysteroscopy? Dr. Orvieto?
We are offering hysteroscopy and usually also implementing during the hysteroscopy or the end of the hysteroscopy scratching with the known debate around scratching, but that's what we offer this patient. After 3 or 4 failed cycles, so we offer them hysteroscopy and then the end of the hysteroscopy was scratching.
So you do hysteroscopy, right? What I understand.
Yeah. After 3 cycles.
Okay. What about Dr. Chiang?
I think the need to arrange for further assessment of the uterine cavity really depends on the patient's history. So it should be titrated against whether there's any risk factors in their history, particularly around previous intrauterine surgery already known, any previous infection, termination which associated with complications, or even early pregnancy, evacuation of products, conception associated with complications. So I think it's about the index of suspicion about anything that is ongoing within the uterine cavity. Because if you think about it, what can we do? Well, if there's adhesions, we would be able to adhesialize. If there's fibroids, we can remove. If there's polyps, we can remove. But other than that, there's really very little else surgically that potentially we can improve. But I think the history and a careful history taking is very important there.
So my question once again, Dr. Chiang, regardless of the history, if late follicular phase, good transvaginal ultrasonography, and good ultrasonography provider, the cavity, the endometrium is entirely normal. Regardless of the history, would you be tempting to do hysteroscopy?
Well,
yes or no?
It's certainly an option I would offer. I would consider offering.
Okay. Dr. Yakın, would you like to comment, Dr. Harper, since you are on the embryology side?
Just to say that from where I'm sitting as a scientist, I know that this has been an ongoing debate between clinicians, okay. And we still don't know the answer. So sure. I don't think we'll find a yes or no answer, but maybe.
Yes, I don't think that there's a definite appropriate answer for this question. But if you ask what have you been doing for this kind of patients, from my point of view, I prefer to reconsider the situation and reevaluate the patient after the first treatment, whether it be successful or not. In a successful treatment, the patient is pregnant, okay, but I believe that we should still look back at the cycle and just reevaluate if there is anything else we could do to improve the quality of the treatment if the patient needs another treatment. That's why we don't have to wait for a certain treatment failures to reevaluate the patient. After an unsuccessful treatment, we reevaluate the patient inevitably. And at that time, do we need hysteroscopy directly? If the ultrasonography shows completely normal findings, we have been doing hysteroscopy for many, many years, and we see that only a few of these patients have significant problems in the hysteroscopies. That's why I wouldn't directly go to hysteroscopy after a failed cycle. If the ultrasonography, the detailed ultrasonography, if you would like to do a solar hysterography, a 3D ultrasonography, if they show completely normal findings, I don't think that qualifies for an hysteroscopic evaluation. But I don't know if this is the right answer.
What about Hulusi?
I don't agree with you this time, Dr. Yakın. I liberally do hysteroscopy. I've done more than 9,000 hysteroscopies so far, and I'm I'm doing hysteroscopy with biopsy, and the pathologist must be familiar with the definition of the endometritis. So even the micropolyp presence decreases the chance of a pregnancy in IVF. So I I don't do regular hysteroscopy before first IVF. I just check the endometrial thickness, maybe do a sonography, saline sonography, but I don't do regular hysteroscopy. But in a failed cycle with a good quality embryo, I usually do and find something. Because my experience showed to me that 90% of the failed cycles depends on the embryo quality or embryo transfer technique.
This is
sometimes
we will be discussing all these issues.
But, the definition of the good endometrium is very subjective. That's what I mean.
Okay. So I also would like to quote the Trophy study, the multi-center study, which also concluded, it's an RCT, that concluded that with otherwise completely appearing normal ultrasonography, with 2 to 4 failed IVF cycles, I mean, you don't add much. You don't add actually on top of normal ultrasonography with hysteroscopy. But still we have the panelists with different attitudes. So it is controversial yet.
It is controversial, and we are aware of the 15 or 20% abnormalities you might find during hysteroscopy, but there is still some abnormalities, like small polyps or something like this. But again, we are doing it not because of the hysteroscopy. We're actually doing the hysteroscopy to exclude abnormalities, but also to offer the scratching. Because we're using scratching despite the known debate in the literature, but because in Israel, you know, that's where the scratching starts. Then
the question comes, what is the impact of these such subtle abnormalities on implantation rate? So we don't know the answer. The second question is, I mean, what is the place of surgery for non-distorting intramural myomas? Dr. Orvieto?
Non-distorted intrauterine myoma after 3 failed in RIF, if the myoma is 3 or more centimeters, we will send it to.
Do you have any size thresholds?
There is no size. The size is in all the. I'm telling you what I'm doing practically, but usually there is no studies that deal with size. Only if it distort or not distort the uterus. But if after 3 failed cycle, 3 centimeters myoma or even more, it's actually half of the uterus, because repeat implantation failure, all the uterus is the myoma. So we are sending to myomectomy, and usually with good results.
Dr. Chiang?
In this context, myomectomy would be my approach, because you've already failed. You will be aware that there's no evidence regarding whether intramural fibroids, when you remove them, will help with the success. But in this context, she's already failed 3 times, so it's certainly an option you have to offer. Well, certainly in my practice, I would do that.
Dr. Yakın?
Well, when you're faced with a helpless couple in front of you, it's hard to continue with evidence-based medicine all the time. But probably the best thing to do is to discuss the situation with the patient. If the cavity is non-distorted, personally, I don't believe that the fibroid has a negative impact on the chance of pregnancy. But still, the patient is having failures, and she is asking for a solution. So you can discuss the patient about the benefits and risks of surgery, and that it could be an option to improve the chance of pregnancy.
What about who you see?
We have shown in a paper that growing intramural fibroids decrease the pregnancy rate. So if a fibroid less than 4 centimeters and shows growth during the stimulation, we suggest to the patient to have it removed. Otherwise, it depends on the patient, because the couples usually want something new for their new cycle, although you know that it won't make any harm. We have patients who delivered after 5th cycle with a 4 centimeter myoma if they didn't want to have them removed.
So the next question is about septum. Very shortly. I mean, would you be considering, even small septa before? I mean, those pathologies would obviously be, surgically treated before the first IVF cycle. But in case you encounter, would you be willing to do surgery?
If it is an arcuate uterus, no. If it is a septum, yes. According to the SRM, it should be protrusion of more than 1.5 centimeters.
Okay. What about Dr. Chiang?
Septum.
It's not written, the uterine septum.
Uterine septum.
Uterine septum.
Again, in this context, given the failed multiple cycles, whilst the evidence is not clear, we know that septums are a vascular structure. It's obviously form of a uterine anomaly. The impact of this is hard or as yet not yet fully investigated by trials. My personal experience would be at this stage, I certainly consider offering the patients surgery.
Yes, my answer would be yes. If we have missed uterine septum in a failed patient, I would definitely excise this septum. But the tough question would be, would you recommend the septum surgery before the first treatment? I don't know if you're going to ask this question or not.
Very shortly, Hulusi.
Septum is not a reason for implantation failure, but it's a reason for abortion. So if you don't want the patient to miscarriage, you should have it removed. Otherwise, it's not necessary.
Okay. There is a trust trial from the Dutch trial. Only, I guess, 19 patients are missing for this trial, and it will be shortly completed. So it's an RCT about the septum on fertility status, and also we will be waiting the results of that RCT. So let's skip hydrosalpinx, but very shortly, if you don't encounter any problem at ultrasonography, no appearance of hydrosalpinx, no intrauterine fluid accumulation, just to be on the safe side, she has surgery or not, would you be considering to do an HSG? Just for diagnosis. I would not be going to the treatment because there is hard evidence that you should be treating hydrosalpinx. For diagnostic means, would you be willing to do his HSG to make the diagnosis?
Of hydrosalpinx?
Yeah.
We're usually in patients that didn't undergo an HSG before treatment during the ovulation induction, so we are asking at the end of the hysteroscopy to make an ultrasound. So if there is some kind of hydrosalpinx, we will see it with the trans-abdominal ultrasound at the end of the hysteroscopy because the tube will be filled with fluid. So that's what we are doing as a routine.
HSG,
no, we are not doing. We are looking for, but if she had the HSG, no problem. If she doesn't, so at the end of the hysteroscopy, not HSG, we are doing an ultrasound to see if there is an hydrosalpinx or not.
Okay. What about Dr. Chiang?
I don't believe ultrasound is a good technique to look at hydrosalpinges, especially when they're small. And also, we do see variations of hydrosalpinges, fluid accumulation fluctuate within the cycle, between cycles. So I do think that in this situation, if you wanted to investigate the tubes, I'd go straight for laparoscopy at dye test because HSG is a screening tool and it's not particularly good for the diagnosis of a pathology. It's good for demonstrating patency, but as far as pathology is concerned, it's not very good at detecting that. So I would go and advise straight to laparoscopy dye test.
Very shortly, Kayhan, very shortly.
Well, she should have had her HCG in the first evaluation indeed, but let's assume she
it's not a routine, so don't tell me that you should have it.
It's a clear azoospermic case that there's an XC indication. Well, I don't know if it would confer any benefits after 3 IVF failures in the azoospermic patient to look for the tubes, whether they're...
So you would be considering it should have it done.
She should have had it.
Very shortly, Lucy, very shortly.
I think it should be somewhere in the second to third cycle attempt.
So the second challenging question, what about the place of immunological workup and also the place of screening for thrombophilia? Just to extend the question before the first cycle or in patients with RIF. Dr. Orvieto?
I have to answer the first. I will be first. Okay. Thrombophilia. There is no place for thrombophilia screening, but we are offering only APLA to this patient because of the association between APLA and the recurrent abortion or implantation failure, if there is any overlap. But otherwise, there's no place.
So you don't offer testing for those, I mean, okay?
Short answer, Chairman, no place.
No place, I fully agree, yeah.
I can say no to that.
Well, they can make a quorum for the no answer. Yeah, I would.
Dr. Harper, would you like to comment?
Yes.
For the thrombophilia,
Okay, no place.
No place.
So,
If you're asking me, yeah, no
Kayhan,
place.
no place,
No,
right?
I would recommend against immunological screening.
But
After
is
all
the issue, yeah, Hulusi, would you like
After all these years, I don't believe thrombophilia plays any role in recurrent implantation failure.
But at routine clinical practice, we have so many patients with all those types of tests have done and the results available in front of you. And this is a common problem worldwide, I mean, all these thrombophilia. And what is more interesting, what I guess, I mean, the immunological tolerance of the semi-allograft of the fetus is, I mean, the normal physiology, the normal tolerance. We should be elucidating more about the physiology of this mechanism, but rather than we are focusing on empirical treatments, which are actually of no benefit, and there might be some subset of patients which might benefit, but we don't know which subset of patients are those. I mean, would you like to comment on this?
No, I agree. I completely agree that probably there is some role or some, but we don't know how to identify the appropriate patient group. You know, if you're looking at meta-analysis, let's say heparin and repeated implantation failure. So the meta-analysis of Nardo showed that there is some improvement and benefit. But if you're looking at the 3 studies included, one of them is in patients with coagulation defects. So, and if you are excluding these studies, so there is no more benefit. So who knows? We have to do more research.
So the next question would be about genetic timing or window of implantation, and also the genetic signature of the recent 2016 paper, or genetic signature of RIF. So do you, at your own practice, Dr. Orvieto, do this error testing personally?
Error test? No.
What is your, I mean, even though you don't do it, what is your personal?
Again, I think that it might be any place to do the error test, but I'm not sure that, you know, recently I had one patient that asked for error test, and it's very complicated to do it through Israel, sending the sample. So I did a mock cycle with PPL and noise criteria. So I found the same out of phase with histology, and after adjusting the progesterone luteal support, she conceived. So I don't know. So maybe in high order repeated implantation failure, we have to look also to the asynchrony between the receptivity and the embryonic age.
What about Dr. Chiang? Would you be considering doing it?
No. I don't think there's enough evidence at this juncture to do it as a routine test. In terms of why, the logic behind it, I don't believe that a cycle before can predict a cycle after. We all see that there's loads of different variation in function with stimulation of the endometrium, and I don't believe that cycle to cycle is identical, which the basis of the test is based on. So no.
I agree with everything said so far. I think it's too early. There's only been a small number of studies from the same center, so we need a lot more data.
Thank you. Kayhan?
Yes, we have to admit that endometrium is not just a receptive organ. It it is very active in the implantation process. It selects, probably directly selects the embryo rather than just allowing it. So there are genetic differences, probably genetic expression differences in patients who can get pregnant or not. But the problem is that the tests in our hands are not capable of recognizing what kind of changes, genetic changes, can show us that the patient can pregnant or not. That's why I would again recommend against genetic profiling. But still, it's a promising area of research indeed, because we know that there are differences. Maybe in the future we'll be able to detect them in more detail.
I fully agree. Endometrium has been greatly ignored. I mean, the most ignored segment of an IRT cycle, the luteal phase support, and also the endometrium. Who do you see? Very shortly.
I believe in the concept of window of implantation, but there is no evidence yet. While I did my postgraduate fellowship at Yale University in 1990s, they were doing a mock cycle 1 month before the embryo transfer for 12 cycles. I think the concept still goes on, but there is no randomized trial or any validated confirmation of ERA test. So I doubt about that.
So the next question is, what about the place of the assessment of the male? Is the male only, we do know that the male, I mean, contributes not only DNA, the mitotic spindle, also some RNA, and in this sense, what is the place of assaying sperm DNA fragmentation, even before the first treatment cycle or in patients with RIF and this sperm aneuploidy screening? Dr. Harper?
I have a lot to say. I'll keep it short. My answer to both would be no. So sperm DNA fragmentation, in my view, there's several different tests. They all measure something slightly different. And in my looking at all of the data, no matter what test, I'm not convinced that it's really meaningful. And if it does mean anything, what we should actually do about it. So I think there may be something there. I think it's, again, too soon. These tests are heavily marketed. And if we look at just what we've on this list here of what we could charge patients with, in our view, none of them having any evidence, I think we have to be very careful. And I think that both of these tests, so the sperm aneuploidy, again, there's no evidence. We don't know what's normal. So if we don't know what's normal, we can't say to a person, oh, okay, you're going to have to do something else. But so I think we need to be very, very careful of data that we don't know how to interpret. If we can't interpret it, what's the point of doing the test?
So the third question is, what can the clinician do? What about scratching? Dr. Orvieto?
So there's actually debate regarding scratching, and there are several meta-analyses, all of them consisting of the same studies, with same results, and there are 3 or 4 studies that are actually dealing with repeated implantation failure, but it was only one failure, and then a good prognosis patient. So the literature is very debatable. Since I'm coming from Israel, and you know that all these scratching issues started with Barash study, so in Israel you are doing scratching.
You do scratching?
Because if you are not doing scratching, it's like you ask why to do a thrombophilia screening, because they came to the professor, and you have to offer something because you're the professor. And if she underwent all the evaluation, so you said, okay, now do DNA fragmentation, no, but thrombophilia screening. Why? Because you have to offer something,
But this is not evidence-based medicine, right?
Evidence-based medicine, completely not.
What about Dr. Chiang?
This is the answer.
Thank you.
Hasn't enough been said?
Okay, Kayhan?
Well, what has to be said has been said indeed. We started PGS in 1998, if you remember, in Turkey, and you were the one who were criticizing us when we were showing proudly our colorful pictures in presentations. We were doing PGS very liberally. We have done many, many patients indeed, and I earned money for that, so it's nice. Then we decided, when we saw that from the colorful pictures point of view, it was nice indeed during the presentations. It was very showy business. But from the patient side, no, it didn't help the patients. And we did our analysis, and we saw that in recurrent implantation failures, the pregnancy rates were even lower in PGS patients. And nobody published our study. They said that since it hasn't shown any benefit, that means that you must have been doing it wrong. So nobody published it. We were able to publish it in a low impact factor journal. But then a smart team showed in a very well-designed trial that it doesn't help. And now the history is repeating itself with the new version. Yes, we have a new version, but everything is same with the new version. Just the version and the pictures and the technique is relatively different. Just like you said, the techniques will be changing in a more promising way. But at this point, we are not giving any benefit to our patients. It depends on what you want to tell to your patients. If you would like to sell PGS, it's very easy to do that, because you say that it increases the chance of pregnancy, it increases the chance of your live birth. If the sentence stops here, the patient will be very happy, but the sentence continues whether you would like to say it or not, assuming that your embryos can make it up to day 5 if they develop into blastocysts, assuming that our technology is 100% reliable and the result that we are giving is 100% true, and we are not discarding your embryos erroneously even though they are normal. If the sentence continues, the patient will not agree to do PGS indeed.
What about Hulusi?
Well, this discussion continues till the morning, so I won't add anything more.
But I also would like to comment. I am a PGS believer.
Yeah, we know that.
I'm a PGS believer. It's not the money issue. I'm very impressed about all the money issues talked about. The PGS. But we did a, cost effectiveness analysis, and we will be presenting at this forthcoming X-ray meeting. And this is cost effective.
Including recurrent implantation.
Based on our prices. So it's not all making money issue. This is a Dutch law. Making money. But so assuming, a woman, so the first point is, why not, that's correct, there are only 3 randomized control trials, and in other patient population, we don't have any data, I fully agree, and the methodology has errors, sampling errors, analytical errors, and also, if you go to Freezall, there is less than 3% non-survival, these are all the limitations, but still, regarding the miscarriage, assume a patient, 42, 43-year-olds, with a chance of miscarriage around 30–40%. You would not make it 0, but around less than 10%. This is an achievement. First, second, the multiple pregnancy issue with single embryo transfer. In PGS era, we should be considering only one single embryo transfer, and we do know that clinics, just to compensate all this morphology stuff, they tend to give more and more embryos, and the multiple pregnancy is an issue. Obviously, PGS would not enhance the results per retrieval, but is it so bad? Is it so bad?
Sorry.
So tomorrow I'm hoping to, during my talk, to use an interactive survey. So we're hoping all the technology is going to work tomorrow. It's worked everywhere I've done it, so fingers crossed. And I will ask everybody not to put their hand up, just on their phone. You have to bring your phone tomorrow. To vote on whether they think PGS should be routine, not be routine, or whether we need more evidence. So we'll hear from everybody tomorrow, hopefully.
Dr. Orvet, are you going to comment on?
They are claiming now, the PGS proponent are claiming now that it's the time to pregnancy is shorter and there is less multiple pregnancy. The multiple pregnancy is a matter of how many embryos you are transferring. So transfer 1. Nobody told you to transfer two blastocysts untested. Transfer 1 by 1. So you will have the same multiple pregnancy. And regarding time to pregnancy, don't forget that even in this good prognosis patient, the RCTs, the pregnancy ongoing implantation rate beyond 20 weeks gestation, so we are far past the abortion rate. It's 46 in the untested and 64 in the tested blastocysts.
So which study is this study? Which study is that?
That's the meta-analysis, the do meta-analysis that gather all these 3 randomized RCT of good performance Scott. Yeah, they do. Yeah. So don't forget that when you are doing PGS, you are cryopreserving all embryos. So you will have 64% live birth rate after 2 months, or she will be pregnant after 2 months. In the non-PGS patient, you are transferring a blastocyst in the first cycle. 45% of them will be pregnant. And then of the 40 or 55 patients that didn't conceive, another 45 will conceive in the subsequent cycle. So it's actually will be 75 versus 64 in the non-tested versus tested. So even the time to pregnancy will be significantly higher if you are transferring an untested blastocyst. So there's actually nothing to support PGS.
Rather than the term time to pregnancy, a better term might be time to singleton healthy live birth.
Again, it is shorter using a non-tested blastocyst because you're transferring a fresh and a frozen toad.
Okay, this is controversial though. So what about the non-invasive methods of embryo selection, Dr. Harper?
So I've written a few papers recently about embryo selection and about evidence for embryo selection. And the one we had out in February, I got other experts and we got a statistician to look at all the data for various technology. So in my view, we need to obviously look at the embryo to decide which embryo to transfer. The good old morphology is still, in my view, the gold standard. I think time-lapse is great for the embryologists. It's great not to take embryos out of the incubator. It's great to see a video of what that embryo is doing rather than a snapshot once a day. But is there evidence to suggest that, or to show, to confirm that using, for example, time-lapse is going to improve your delivery rate? And the answer to that question is no. There is no evidence at the moment that time-lapse will improve delivery rates. So I think it's a fantastic piece of kit. It's excellent for the embryologist, and it is the future. We will automate more and more of what we do. So I think it has many advantages. I think it's a shame that we can't see any improvement. I think we got very tied up in the algorithms, and there's people here that know a lot more about this than me that will be talking about this. I think the algorithms, they just can't be transferred from one lab to the next. There are so many variables between labs. Even if you use exactly the same lab consumables, you're in a different environment, in a different building, and the building is exposed to so many different particles and things that you can't transfer some of this technology from one lab to the next. So I think it is the future, but I think it's there's no evidence for that.
What about mitochondrial health?
That's taking a deep breath. So are you suggesting doing the mitochondrial load, measuring mitochondrial load? I will talk briefly about that tomorrow. My slide just says no RCT on it. So again, it's another thing you charge your patients for. And I know that there's some labs that are doing PGS, and they do PGS, and they do mitochondrial load, and they do gene expression, and blah, blah. Very high tech, looks fantastic, makes a lot of papers that we can publish. But if there's no evidence, I don't understand the point of doing that. And if you look at the small number of embryos this has been applied to, it looks interesting. It looks like there can be something there. If there's something there, just prove it. Do multi-center RCTs and show us, and then I'll be very happy.
With this opportunity, I also would like to quote the very recent study by Dr. Harper, published in the March issue of Human Reproduction on the role of adjunctive empirical treatment in IVF setting, and also the 2013 study, very skeptical, the lab side on the need of RCTs. And what about assisted hatching? I mean, this is a simple question though.
Assisted hatching.
Oh, God. So, all the evidence on assisted hatching is that it doesn't work. And I've spoken to people recently who've said to me, but nobody does assisted hatching anymore. And I've said, yes, they do. And they said, no, they can't do. And I gave a talk, I gave the adjuncts talk in a conference recently in Egypt. And Jacques Cohen was in the audience. And Jacques Cohen was really the founder of assisted hatching. He was upset. He was upset by my interpretation that there is no evidence. So he said that for a small subgroup of patients with different things that it is, but the published evidence is absolutely black and white. On my slide tomorrow, it will say this is the one where it says no evidence at all. The others say limited evidence, but this says no evidence.
What about adding the colony stimulating factor in the culture medium? Dr. Harper?
Okay, so the company marketing GMCSF that they were adding to the media, this single growth factor, they did everything by the book. They did the research and development, they did the RCT, which cost them millions and took many years, and they had problems having it published. But their evidence showed that from their study, only a subgroup of patients, and it was very clear in their study, it was only a subgroup of patients that seemed to show a benefit. And that when you looked at that subgroup, the numbers then became too small really to extrapolate. Really a further study needed to be done. But this is an example of where we take studies telling us something for one group of patients and we start transferring it to another. And I think we have to be very, very careful about doing that. I think there may be something in growth factors, but growth factors are very complicated. And there's not a single growth factor that works on its own. They work, I always say they work as an orchestra. And different growth factors are turned on and off at different times, depending, if you like, the symphony that's being played. And I think we have to be very careful to start messing around with this. So when the year that the RCT was published, and they did a wonderful presentation at ESHRA, in the foyer, the company had all over their banners, GMCSF reduces apoptosis, increases metabolism, and I can't remember the last one, but those two are the reverse of what you want. So I went up to them, I said, what are you saying here? You know, most of us think of the Henry Lee's quiet embryo hypothesis as the good. You're saying you're increasing metabolism. Why is that a good thing? And reducing apoptosis in an embryo, apoptosis is a normal event. So to reduce it, I don't necessarily think would be a good idea. Now the materials stopped saying that after that year, it all got taken out. But I think that just shows some misunderstandings that can happen. So we have to be careful.
There is also a major flaw in that RCT, 2013 RCT. What I remember is that the concentration of the human serum albumin was changed just in the middle of the RCT, which is totally unacceptable. It wasn't perfect. And also the culture media in that RCT is not the same that the company is right now offering. It's different. Yeah. What about the higher and enriched transfer media? Dr. Harper?
You're making me work very hard. So, when we've looked at this, and in our paper, there is evidence that this has a beneficial effect to live birth rate. But again, when we've presented that to different audience, some people have said, no, we don't quite interpret that. So I think all of this list shows that we do have a problem where we have two, like we have with PGS, we have two camps where people have read the same papers and the same information and have come up with a different interpretation. So I think of all the ones on your list, this one does have evidence. That's my view from my interpretation of the data.
Okay. So the final question is, keep retrying. When enough is enough, Dr. Orvieto?
So in Israel, there is no enough. The enough is 40 years old. So the government is subsidizing IVF until the age of 45.
No, I mean not only the female age, I mean say a younger
When?
patient?
So we're actually
so how
doing.
many cycles would you consider? I mean, enough.
I'm seeing patients undergoing their 10th cycle, the 20th cycle, and 25th cycle. And there are still few pregnancies even in the 20 rank.
Yeah, but obviously with each cycle, I mean, per cycle
I think that the pregnancy rate is actually same for the first 3 cycles, reduce a bit until the 6th cycle, and then it goes down to 5–10% until even the 20th cycle.
But also in Israel,
That's what I'm saying about Israel. We're doing
reimbursed, right?
Yeah, so we are doing. So that's why we are doing. There are patients in Israel that are the way 30 cycle, because what stopped them is the age of 45.
So in your, I mean, just personal practice, you would not deny IVF just based on the number of previous IVF cycles. Retry,
No,
right?
no, if it's not futile.
I'm sorry?
If it's not futile, if not a patient with one lazy embryos or sometimes without any embryos.
Yeah.
A repeated implantation patient with.
I
will continue. Yeah.
Okay. What about you, Dr. Chiang?
I think it's enough when the patient says enough. So IVF is known to be of high burden in terms of psychological, emotional stress. We talked about stress. And it's our duty to help them navigate this journey as stress-free as possible. But the literature data and my personal experience is that patients do give up because it's too stressful. Whether it's funded or not, they feel so much stress that for some of them, after one cycle, they say no more. I think as clinicians and healthcare professionals in the IVF area, it's our duty to make sure our clinics, processes, and our way of approaching our treatment lessens this stress as much as possible for the patient. So it's when the patient says it's enough.
Okay, Dr. Harper from the lab side.
So I agree. I think it's very individual. I've seen patients give up after one cycle. I've had friends give up after one cycle, and then I've seen people go through more than 10. So every couple is individual, and as healthcare professionals, we have to support them in their decisions. Some will decide to go for egg donation or sperm donation, and some may even resort to surrogacy. But that's not a journey for everybody. So we just have to listen to the patient and not force them to carry on because we want them to. We've got to listen to them.
Thank you. Kayhan?
Well, we have seen extreme cases. Indeed, patients with good quality embryos probably should be encouraged to try again if they have good quality embryos. They still have the chance of getting pregnant. There's no such a limit for them not to try anymore. But for those ones with poor quality embryos, we should tell them that it's very unlikely for them to get pregnant if they keep on trying. In our culture, as you know, it's not an easily given decision. Donation is not an easy decision for our patients. But at a certain point, we have to discuss about other options.
Who do you see?
It depends on the patient. When the patient is exhausted, they should stop. In Israel, where all IVFs are reimbursed, they go up to a huge ratio of the patients go up to like 13 cycles. So it depends on the patient's stress, and their support. If there is a culture that they should bear a child, they go on, like many of our patients do that way. So my record is 9 cycles. I have delivered 2 patients at their 9th cycle. So as Kayhan said, you should direct away, but the couple must decide what to do.
And the final question before coming to the audience, just very shortly, what is your upper female age limit that you would deny IVF, Dr. Orvieto? 45, including 45, right?
45 first.
Okay.
That's the regulation.
Okay.
Marketing Act 44. That's the regulation.
Okay. 45. Okay.
45.
Just based on okay.
43.
43.
So with their own egg?
Yes. Autologous eggs,
43,
obviously.
44, yeah.
43, 44. Kayhan?
44.
44.
44.
We deny.
So that was actually the end of my questions. We might be taking several questions, not too many from the audience, if there are any. Yes, Ercan.
Bir saniye geçelim.
My question is to the Joyce Harper. Can we evaluate the embryo culture media for assessing the embryo quality, like metabolomics and genomics and other things as well?
Metabolomics.
Yeah, we've done a little bit of work on culture media, looking at metabolism into the culture media. I think there's something in it. Henry Lees did a lot of work on looking at amino acid profiling, and unfortunately, one of the companies took it up, and they never ran with it. And I know he's very disappointed as well. We had the molecular biometric system that Derin set up about 10 years ago that was not ready. Unfortunately, they took, again, I think they probably had something there, but they took it too quickly before they'd really worked out algorithms, et cetera, and again, I think algorithms are a problem in transferring data between different labs. So I think there's something there, but it's not fashionable so much at the moment. Everyone's interested in genetics. So yeah, I think we should revisit that.
Thank you.
Any more questions? Okay, the panel is over. Thank you so much for attending.